This isn't being recorded. Oh, now it is.
No.
Hello, recording.
Hello. Oh, Senator's here.
Well, I can get you all your IPPE hours.
Good morning.
Are there
Good
a lot more?
morning.
Are there a lot more seminars now that things are virtual?
I think it's much easier to do these seminars because we don't have to have the people come to the school.
Yeah, and you don't have to worry about rooms. You don't have to book rooms and all of that stuff. You can host a seminar at any time of the day.
I think this should be a trend. Like, I mean, it's nice to have people come in, but it's just more feasible.
I mean, I feel like it just created this opportunity because, like, now you could literally have people from all different schools, and like you're going to integrate this. Even if you go back in person, you could still have people. Like, you can still have it broadcasted online.
Yeah.
Good morning, Senator. Good morning, Hussein. Good morning, Obi. Good morning, Evan.
Good morning. I'm real excited for today's
morning.
seminar.
Good morning. It's one of our panelists, Hussein Safari.
Good morning. Good morning.
This should be an exciting one. Accountable care organizations and value-based care. This is going to be great.
You have to turn your camera on if you want to talk. That's what Zach said.
Yeah, I want to see.
Accountable care organizations and value-based care. I'm real excited. Happy to be here.
Hey, can you put on the blur background or get a more?
Oh man, Obi, what's up, bro? Is he on? Is he even on? Ask him to unmute.
He's on here. He's on mute. It looks like.
He might just. Are you done with class? You're done with class already, Evan, right?
Yeah, we just got
What time does class technically end?
11:20
11:20. Okay.
or 11:50. It's either 11:15 or 11:20. Like as soon as we got out, I joined here.
Evan, when is your last exam?
For school, until spring break.
And for the semester?
Let's see. I think April 30th.
You don't have a PCL one on, or a PBS, or a self-care on May 4 or something?
Oh,
Good morning, Brooke.
Good morning, everyone.
Morning.
Brooke's at every one of our seminars. I love it.
I know.
It's good.
Yusuf, where do you get your suits
Attend
from?
as many as you can.
Where do you get your suits? Yeah, like it's like you always have something different on. It's like it's kind of.
I have a whole bunch. I here at home. I have lots of sport coats and things. This is a gift. This is a gift. I like it. It has like the patch.
You look good.
Thank you.
He looks good all the time. He looks good all the time.
Only when we have to. At the house, I'm just in sweatpants and a hoodie or a drug rug shirt, whatever.
All right, keep deceiving us. It's okay. It's okay. We'll take it.
So we'll give it a couple of minutes before we get started, just because some people might be leaving class late.
That's
Good morning, Rachel.
And I have some pauses for questions, comments, and where I talk with you guys. So if we cut into the questions at the end, I think we'll be fine. If you want to wait a couple minutes for people to trickle in.
Yeah.
Can you imagine, Zach, how much your baby's grown?
You guys are doing well. Good to see. It's good to see.
I gave up on the announcement. I was like, it's not coming. And then like it was like 5:30, and I checked my email, and they sent like the newsletter. And I
Yeah,
didn't see the name was like alphabetical. And I was like, oh no! It's
I
happening.
wish they sent it 5 hours earlier so we could have put it in the mask, but
Should be exciting.
when do you guys compete again? Like, or are they going to judge the work that you've already done in the
No, we have
finals?
to actually present it. So we made a PowerPoint. That's like the second part of it. And we have to actually present the PowerPoint. It's like a 20 to 25 minute presentation. And then there's like questions alongside with that.
You got this.
And we're going for gold.
Got it.
Just let me know when you're ready to start.
Yeah, we can get started, and then some people will jump in as we get started. So good morning, everybody. Welcome back to the second part of our Managed Care Seminar Series. My name is Fadi Manuel. I'm the current president of AMCP. Today we are welcoming one of the founders, actually the founder of AMCP chapter here at Wayne State, Dr. Zach Mueller. He's a former Wayne State alumni, recently graduated. He's currently working at the MPA. He's an executive fellow, and he's going to be talking about accountable care organizations. So I'll let Zach take over, and then he's going to have some polling questions throughout his presentations. But please feel free to send in your questions in the chat or to Joseph, and we'll just go through them and then ask it at the end. But also, if you want to, just chime in the middle of the presentation, ask a question, feel free to do that as well. So I'll let Zach get started, and then hopefully you guys enjoy this presentation.
Well, thank you for the introduction, Fadi. And for those of you who don't know, actually the AMCP P&T competition team was named for the finalists for the P&T competition nationally. So glad to see where you guys have gotten to after we started it a few years ago. So that's awesome to see. As Fadi said, I graduated last year. I'm the current executive fellow at the Michigan Pharmacists Association. And so my background's more on the association government side, but I do have managed care experience, did internships and rotations with Blue Cross Blue Shield of Michigan. And so what we're going to be talking about today, and what I hope you can get out of it, is be able to contrast value-based care and fee-for-service payment models, explain accountable care organizations, and describe the opportunities for pharmacist involvement in an ACO. And just as some background, I gave a similar lecture to the P3s during the fall semester. And for those who aren't there yet, in that semester, you actually are tasked with creating an ambulatory care clinic design and kind of pitching it to an ACO. And it's Dean Lucarati and Dr. Salinitri who are the who you have to try and contract with. So it's a fun time, but really speaks to the real world of pharmacy and where we're trying to expand services, and how do you explain that business model and how do you get involved to expand the services of pharmacists. And so just to start here, to see if our polling functions are working, I just have this poll here. If you can go ahead and answer that so we can just see if polls are working. And what is your favorite season? And we're getting into the spring here, but I don't know if anyone's, somebody did put winter. So you're a brave soul, whoever put that. But I see a lot of people are looking forward to summer and fall here. So that's good. I'm looking forward to some warmer weather. So we can end that. And there you go. We can see everyone agrees with me for the most part. Okay, so what we'll do. All right. So just a historic perspective is in the US, we've been trying to get a hold of healthcare reform for quite a period of time. Medicare and Medicaid were started back in the 60s. In the 70s, they came out with HMOs and PPOs. 2007, the patient-centered medical home design came out. In 2009 was the Affordable Care Act, under President Obama, which gave rise to ACOs. In 2019, they had some other primary care initiatives. But as you can see, we have a long history of trying to reform healthcare and healthcare payment to reduce spending, but provide adequate care to US citizens. And so here is kind of a little grouping of different payment methodologies. On the far left in category 1, there is fee for service. So no link to quality and value, it's just fee for service. You go in for a doctor's appointment, doctor gets paid, transaction is done. In category 2 there's a link to quality and value. So one of the examples there is pay for performance. And so there you would get incentivized based on how many people get admitted to the hospital, or how many people have an amputation if they're a diabetic, things like that. And the better you perform, the more money that you would get. And then there's these APMs built on fee-for-service architecture that talks about shared savings and risk. We'll get into that a little bit more with the ACOs. And then on the far right is population-based payments, where you can kind of think on the far left is transactional. There's a service, and then there's a payment. In category 2, there's an individual based on how they do. There's a service and a payment. On the far right, population-based, you're getting paid on the outcomes of a population, and it's more centered on the group than necessarily one individual. And these are just some examples of different payment methodologies and value-based metrics. So fee-for-service, that far left category, payment is transactional, and providers are paid based on the quantity of services rendered. And so we're going to see what that looks like. And so if you just take a look at this table here, so Dr. J sees 16 patients today, and his reimbursements are shown below. He had 16 office visits, and he's really efficient, so they were all 15 minutes, and he gets reimbursed $90 per 15-minute office visit. He had 16 of those, 90 times 16, made $1,440. And so if you go down this list, you can see that the payment is just cost times quantity, and you add all of that up, and you get his payment for the day right around $2,000. And so we're going to contrast this to value-based care, where pay is focused on the outcomes of patients and not the amount of services provided. So providers are accountable for the quality of care and the cost of that care. So if you think about this, it is going to be a little bit more involved. We're going to need more metrics. We're going to need ways of keeping track of quality of care and how people are doing. So if you take a look here, and this is an oversimplification of value-based care, but it's a bundled payment model. And this is just going to look at one patient here. RJ is a stroke patient who's been in the health system for 7 days, and he was admitted 28 days ago with a similar diagnosis. So he was discharged, and now he's back. So a stroke diagnosis, there's a $10,000 bundle payment. The testing and procedures that they did cost $2,000. The medication and fluids cost around $2,500. It was a readmission, so they were docked $500, and this patient stayed for 7 days, which $500 per bed per day, $3,500. And there was a exit survey when he left, and so the quality rating that he gave wasn't great, and so they were docked another $250. So of that $10,000 bundle payment, they're left with $1,300 for this 7-day stay. And this is just an example with arbitrary numbers. These are not real numbers here. But I want you guys to take a look at this and tell me what are ways that a provider could cut costs and increase savings from the last example. So I'll go back to it. And I want to hear from you guys. And I don't like just lecturing at a screen, so I'd like to hear your thoughts and make sure that we're thinking the same thing. So if anyone just wants to unmute themselves and go ahead and tell me where in this model you think you could cut some costs. I'm patient.
Probably with the readmission.
Yeah, so if he wasn't
The
readmitted,
hospital stay, yeah.
yeah, in hospital stay. So the readmission, if this wasn't a readmission, you would end up making more money. And if that hospital stay, if you decrease that stay, would end up increasing that bundled payment, how much that you would make. Anywhere else?
The quality rating, patient
Yeah,
quality
so
rating.
Yeah, so the quality rating. So there are surveys, exit surveys that some hospitals give patients. So, and some of the things on there are education about your medications, discharge instructions, things like that. They get rated for quality. So I think a pharmacist is positioned pretty well to do some medication education and to help patients with their discharge information, where you could make money per patient on those quality metrics. So we're going to keep going. And so value-based care, to determine quality, value-based care contracts, as we were talking about, require collection and reporting of data related to outcomes, harms, and cost. And so some of these metrics on a clinical care perspective, there's heart failure, 30-day mortality, pneumonia, 30-day mortality. For safety, that's C. diff infections, catheter-associated UTIs. They look at efficacy and cost. And so Medicare spending per beneficiary, how much does Medicare have to spend on your patients versus another organization's patients? And are you constantly needing more money to take care of patients? And why is that? And then person and community engagement, so communication about medicines and discharge information. That's kind of what we were talking about with those surveys, is how that's measured. And so just another poll here. If you could pick your contract on how you're reimbursed, so you're negotiating contracts, what would you pick? Just out of curiosity here. You could answer that for me. So that 8 of 20 respondents, got about 70% of you. Just a couple more left to weigh in here. All right. So we'll end the polling and I'll share the results there. So looks like a lot of you wanted to do value-based care. There was a couple of you who said fee-for-service. And so I'm curious, fee-for-service, folks, why did you choose fee-for-service? If one of you two, I know there's only two, so you're kind of on the spot here. But if you wouldn't mind unmuting yourself and explain why you went there. There's reason to go fee-for-service. Does anyone care? Well, so the majority of you put value-based care, and so in a fee-for-service model, there's a lot less reporting. You don't actually have to collect as much data, and so when you do a service, you get paid for it. In value-based, one of the barriers is you have to collect more. You're gonna have to collect more data, and you're gonna have to use that data, and you're gonna have to get judged on that data. Rather than just providing a service, you're gonna have to justify your services. Not saying that value-based care is wrong, but that would be an argument for fee-for-service. Value-based care, you're obviously caring more about the patient population and patient health and trying to drive those costs down. So as I talked about in the beginning, the reason we're all doing this is the cost of healthcare. The reason we keep trying to reform it, I'm sure you all have heard about that. Global healthcare spending is projected to increase at an annual rate of 5.4% per year from 2017 to 2022. It was 7.7 trillion in 2017, 10.1 trillion in 2020. And there's 3 trillion of waste each year. US accounts for 1/3 of that, 1 trillion of the waste. Medicare spending grew 6.4% over the course of 2018, and prescription drug spending, so kind of our realm, increased 2.5% in 2018. And so when we talk value-based care models, there's accountable care organizations and there's others. And so we're focusing on accountable care organizations because that is what you are contracting with in your third year of pharmacy school. So that's really what the focus of this on. But there is other value-based models that are out there that you can get involved with and that are driving healthcare.
That percentage outpaces inflation, annual inflation in the U.S.
This, Johnny, you're talking about this?
Yeah,
here?
the 5. Yes.
Yep, and I think, and it's a large percent of our GDP as well. And so as a country, we spend a lot more on healthcare than most other countries. And we're really trying to wrestle with how to bring that spending down. But it's important to note that we don't just want to bring spending down. We want to keep care and healthcare the same or better. We want to improve care, but spend less. And that's really the conundrum that we have here. And so one of the reasons, or one of the ways that we tried to do that, brought about by the Affordable Care Act, was the Accountable Care Organization. So it's groups of doctors, hospitals, and other healthcare providers who come together voluntarily, and they coordinate high quality care to Medicare patients. And there are other payers besides Medicare, but mainly Medicare. And they try to provide the right care at the right time while avoiding unnecessary duplication of services and preventing medical errors. And so there's a little video I have here to play to help explain that a little bit better than I can. And it's fun, so give it a second.
The Affordable Care Act isn't just a new way to get health insurance. It also ushers in a new approach to care. Meet the ACO. An accountable care organization is a network of doctors and hospitals that shares financial and medical responsibility for patients. The goal is to coordinate care and eliminate unnecessary spending. Medicare set these up around the country, and private insurers have too. In the health system today, patients are usually responsible for coordinating their own medical care. Someone with heart disease may see a proctor, a cardiologist, and maybe even a heart surgeon. But the doctors might not talk much, so they could order repetitive tests or prescribe conflicting drugs. That isn't good for the patient, and it's expensive. It's also not the way things work in most other industries. Imagine your car won't start. Now imagine that to fix it, you had to schlep to the transmission whisperer, the battery baron, the timing belt tycoon, and the piston professional. Each would only look at their piece of the car and not think about how the parts work together. That makes no sense. Instead, you go to an auto garage, where an organized crew works together to make your car run again. An ACO brings that kind of coordination to your medical care. Your doctors, imaging specialists, surgeons, hospitals all work together and share information to figure out the best way to fix you up and keep you healthy afterwards. What's in it for the ACOs? ACOs that save Medicare money get to keep a portion of that savings, if the doctors and hospitals can show they're doing a good job keeping people healthier. So, are ACOs working? Well, the jury's still out. It's unclear how much money ACOs save, and some organizations that tried to form ACOs have quit. There are also concerns that ACOs could reduce competition and lead to higher prices. Wait a minute, how is this different from an HMO? ACOs have been accused of being health maintenance organizations in disguise. Both depend a lot on a primary care doctor who coordinates care. But there are some major differences. Patients in HMOs are covered only when they see doctors that are part of the HMO. In a Medicare ACO, patients can also see doctors outside the ACO. Shouldn't we worry that an ACO can save money by cutting corners? ACOs get graded on a list of quality measures to make sure no one skimps on care people need. These measures don't yet track all aspects of care, but the goal is to give ACOs financial incentives to keep people healthy instead of just treating them once they're sick. Want to learn more? Go to the address on the screen.
All right, so that was a quick little video to give a snappy overview of affordable or accountable care organizations. And as you can tell, it's about putting the patient in the middle and trying to not duplicate those services, but to try and provide services, and for each professional to provide the best service that they can in their area of expertise. And so the goal of ACOs is to improve care for individuals, improve the health of populations, and reduce the rate of growth in healthcare expenditures. And so this all comes down to their accountable care contracts. And so with CMS, the Center for Medicare and Medicaid Services, it's a 5-year contract. And as they mentioned in the video, they collect data based on cost savings and performance metrics. They submit data to CMS for the basis of shared savings and shared losses, which we'll talk about in a minute. And you share in the earnings of those savings by CMS. In 2019, there were 541 ACOs in the Medicare Shared Savings Program, or MSSP. They generated $1.19 billion in total net savings, third year in a row that the program achieved net savings. And that was an average of about $100 to $170 per beneficiary. But the important thing to note is it was comparable or better quality performance on measures compared to other physician group practices. Because what we said the goal was to drive down costs, but to provide better or same quality of care. And so far, they've been doing it, but not for a whole long period of time. And so Medicare is the primary payer for ACOs, but there are private, employer-funded, and state Medicaid. They establish performance metrics and incentives to measure quality of care. And so we talked about risk earlier. I said I would get to it. So risks focus on the big picture. CMS incentivizes ACOs and other organizations to share in the risk of healthcare spending to promote cost-effective care. And there's one-sided risk and two-sided risk models, which we'll talk about in a second. Keep in mind, the bigger the risk, the bigger the reward. And so in one-sided risk, this is also called upside risk or shared savings. And it's the ability to earn all or a percentage of any savings during the performance period. And so what they do is they set a minimum savings rate benchmark, an MSR, that's needed to keep their costs to qualify for shared savings. So they'll set this MSR, and then where you are in relation to it will determine whether you've saved money. And if you've saved money, you get some of that money back as a reward. You're not financially punished, though, if your costs are above that MSR benchmark. This is contrasted to the two-sided risk model, which has upside and downside risk. So accountable care organizations are held accountable or financially responsible for all or a portion of the financial losses if actual care exceeds the MSR, the financial benchmark. So in the other model, you weren't held responsible if you went over, but you shared savings if you were under the MSR. Here, you actually would lose money if you go over your benchmark. You still have the upside shared savings. This is obviously a little bit less popular, but it's being promoted by CMS. And so here are some, here's a table to help us understand it a little bit better. And so here in the one-sided, there's a 50% shared savings that the health system would get. In the two-sided, there's a 75% shared savings, but also a 50% shared losses, or the downside risk. And so all of these, we sent the benchmark MSR an arbitrary number of 1.5 million. So that'd be a pretty small hospital. And so for Hussein's health system, the benchmark is 1.5 million, and he actually billed $1,869,500. In the one-sided payment model, since he doesn't have any downside risk, he still gets paid about his 1.9 million for his services. In a two-sided payment model, if you can tell, he only gets paid about 1.7 million, despite performing 1.9 million in services. And this is because he went over that MSR and he has a 50% shared downside risk. And so he actually ends up losing about $200,000 worth of services that he provided. Rachel's health system, on the other hand, same benchmark MSR, 1.5 million, but she only billed 1.2 million, or 1,230,000. So in a one-sided payment model, she gets 50% of that back. So the $270,000 that she saved Medicare, she gets 50% of that back. So she gets $135,000, which is about the price of a pharmacist if you want to hire one. And then in a two-sided risk model, she has 75% shared savings. So she ends up making more money since she was under the MSR. So here she makes $1,432,500. And that netted about $200,000 over her services rendered. So she gets more money because she took the riskier contract. But if she would have been over like Hussein's health system was, she would have lost money. And then Steve's health system at the bottom here is just a Another example with more savings than Rachel's. So if you can see in the one-sided net areas, he ends up gaining more money over his services rendered. So the more you save, the more money you make back is really what the takeaway is. And so another question for you all, if you oversaw the contract negotiation with CMS, which would you pick, a one-sided risk model or a two-sided risk model? Got about 50% of you in. Most of you are pretty confident that you'd save money. Waiting on a few more to lock in their poll here, if you could. All right, we'll end it there. So only one of you picked a one-sided risk model. Can I hear from somebody who picked a two-sided risk model why they'd pick that one over the one-sided risk model?
Isn't it sort of akin to like hedging your bets? You're spreading the risk out so you can sort of get the benefit of, as opposed to taking on the one-sided risk model.
Well, on the one-sided risk, you actually don't have, there really isn't much risk. So you only share in the savings. If you spend too much money over your MSR, in a one-sided risk model, you are not held financially responsible. In a two-sided risk model, you're held financially responsible if you spend over your MSR, but you gain more money if you spend less than your MSR.
That wouldn't happen with the one-sided risk.
One-sided, you're not held financially responsible. So in Hussein's, if we go back to that, let's, if you see Hussein here in the one-sided risk model, his payment is 1.9 million. And so he ends up, because he's not held financially responsible, so he just gets paid at business as usual. In the two-sided risk model, he loses $200,000 because he's over the MSR, and so he would have been providing services for free to quite a few patients, because he's not getting paid for those services because he's gone over his cap in a two-sided risk model. But majority of you picked the two-sided risk model, which is fine. I will go to my quote here is, you cannot be fully accountable for patient population health until you're willing to accept risk. And that's why CMS is pushing more people to a two-sided risk model, because they want to hold the health systems accountable, that if you spend over your money, you're not getting all the pay for it. That it makes the health system think about their spending a lot more. Because in the one-sided risk model, it's really a win-win for the health system. If they don't spend enough, they still share in the savings. If they spend too much, they're not held accountable. In a two-sided risk, you have more skin in the game. And so that is why CMS wants more health systems to move that way. And so if someone can answer this question for me, how do you think an ACO would benefit from a pharmacist? What do you think a pharmacist could do for an ACO?
I'll chime in on this one. I mean, you mentioned like the cost earlier, with like the hospital costs regarding admission. And the first thing that popped in my head is like medication reconciliations. And usually when a patient is discharged, the Medirecs are not done properly. And I feel like that's a prime area where pharmacists can intervene and prevent those hospital readmissions. So that's like a major area that popped in my head as soon as you presented that example.
Yeah, and we see more health systems in, especially in Michigan, that are trying to get pharmacists more involved, or at least pharmacy technicians actually have a certification for med histories now, and getting the pharmacy department more involved with this process for those reasons. Does anyone else have a?
Pharmacists could do potentially more of the sort of the metric end of it, so that that portion that needs to be a part of what you were mentioning earlier, having more metrics in play that will be responsible for that model. Pharmacists could sort of take that on.
So you're saying that the sort of the natural position of pharmacists with the EHR system, and how drugs are dispensed, and we have a lot of control pills out of my 1,000. So you think we could take that sort of model and pull it over healthcare? Is that what I'm hearing from you, Johnny, or expand on that and run it?
Actually, you kind of broke up for a minute there.
Oh, did I? Oh, sorry. I was saying that, were you drawing a natural connection between pharmacy and electronic health records, and how all of our stuff is generally documented very well in a pharmacy?
Absolutely.
We have to keep tight control, and there are a lot of metrics for patients on X drug.
Yes.
That's what you were thinking? Yeah, I think there's certainly an area there. In the interest of time, we're going to keep going, but pharmacists can increase access to care, so that people aren't foregoing healthcare. If you're involved in, physical exams, helping with that sort of thing, doing blood pressure checks, and they don't have to go into a doctor visit. If they can get a blood pressure check while they're picking up their prescription, you're lowering the exposure on the system. Increase quality of care. We can provide guideline recommended therapies, and we can save money by sort of what Fadi was talking about in preventing readmissions and drug-drug interactions that are costly. And so pharmacists improve patient outcomes as medication experts that optimize drug therapy. We can recommend cost-effective alternatives, prevent drug-drug interactions, recommend preferred therapy, avoid duplications or unnecessary medications. Our struggle is we need to form relationships and provide proof of program impact on current practice. And so in an inpatient pharmacy, medication history and med recs by pharmacy, on discharge, on admission, post-discharge, transitions of care, really making sure that patients know what medications that they're taking, is really important. One of my colleagues said to me in our 4th year rotations, drugs don't work in people who don't take them. And so if people aren't taking their medications, they're not going to work. If we're trying to, we could provide the best care in the world to try to prevent their next stroke. If they're not adherent to their medication, it doesn't matter. They'll be back. And that is another expensive visit. And even more than just an expensive visit, that's somebody's life. And so, and that's their family's, their grandma, their grandpa, and those sorts of things. And then patient education at time of medication initiation. So doing a lot of warfarin counseling and things like that, so that people don't come in with massive bleeds. On the outpatient side, patient counseling, that goes back into that education. We can do disease screening and monitoring, as I mentioned, blood pressure screening, point of care testing. So doing COVID tests, so somebody doesn't go to the hospital thinking they have COVID when they really have the flu. And then they potentially get admitted while the test is going on. And those are expensive visits. And more can go wrong when it happens on the inpatient side than on the outpatient side. Immunizations, we can do immunizations in a pharmacy. We can go to community sites and do immunizations and get people immunized so that they don't end up with a pneumonia admission in the future. We can do medication therapy management. We can talk to patients about their drugs and catch drug-drug interactions. And we can get involved with chronic disease and help patients understand their medications and that they need to take them. So some of the barriers to pharmacist involvement, though, billing for rendered services directly. And as you'll learn about in that same course, your P3 year, they'll talk about billing incident 2 and how services are rendered. And so pharmacists lack a strong billing structure that we can bill for things directly. Our main reimbursements come from the filling prescriptions and the reimbursement there. The services that we do on top of that don't always have a lot of dollars attached to them. Communication across the healthcare continuum. If you work in a community pharmacy, and I also work weekends at Walgreens, if a patient comes in with a medication, I can't look up, or with discharge meds, I can't look up what happened to them in the hospital. I don't necessarily always know what is happening to provide a quality of care that will prevent them from being readmitted. I may not always know what is going on with the patient, and that's hard to get involved if you don't have the full picture. Identifying high-risk patients. A pharmacy, everyone in healthcare is busy. There's a lot going on. One of the hardest things to do is you have to understand where to spend your time and resources to have the most impact on your patient population. And so that is what you'll have to do, is identify high-risk patients. And then measuring pharmacist quality and financial impact. With the billing being a little bit confusing, it's hard to always understand where, what impact a pharmacist is having. And so that is one of the challenges. And we work on it every day, but I've been involved in projects where we talk about getting a pharmacist involved, and they say, where's the revenue? What's the revenue that the pharmacist is going to bring in? We often talk about cost savings. A lot of hospital administrators want to see revenue, and that's one of the hard things for us to prove. And so ACO involvement, health systems that are being reimbursed based on performance and or savings benefit from pharmacists who can increase guideline filed therapy and decrease spending, thus increasing that shared savings to the MSR that we talked about. And so in the future, if anyone is trying to join an ACO or present an innovative model to a health system, the things I want you to think about are what gaps are there to fill, how much does your service cost, how much revenue can you generate, what costs can you eliminate, and what are the barriers to implementing your service. And these are the questions you'll ask yourself in P3 fall when you're creating that ambulatory care design. And so with that, are there any questions for me?
Okay, I've collected some questions here, and someone is asking, what exactly is the P&T competition, and what do you have to do?
Well, I think that's a question for Fadi. So I will let him.
Well, first I'll start off by saying thank you for your presentation, Zach. I think you touched on a lot of great topics that we could expand on in the future. And I hope you guys gain something from this presentation. When it comes to the P&T competition, it entails coming up with a drug monograph, which is basically, explaining why a certain drug, is doing good, looking at the clinical evaluation of the clinical evidence and evaluating it when it comes to that drug. Also looking at the economic evidence and seeing, is this drug cost effective, as Zach was mentioning. So it's just bringing all of that together and into a monograph. So our monograph for the competition this year was 40 pages long, where we went through why do we think this drug should be in tier 1, tier 2, tier 3, tier 4. And that's something that we mentioned during our the first part of our seminar series. So just determining why should it be in certain tier. And you do that by evaluating the literature. Is the evidence, is it weak evidence or is it strong evidence to support using this drug? And then you look at whether it saves money, does it generate revenue? And if it doesn't, there is really no reason why it should be like tier 1 or tier 2 or tier 3, because if it's not saving money in the long run, it's not something that the health system or the pharmacy can use consistently, because they're going to be losing money. And if you're losing money, you're not going to be you're not going to be able to operate at some point.
Okay, so for those of that joined us late, this is a landmark year for AMCP Wayne State because it's technically our first year as a RSO. And as Fadi announced earlier, just yesterday, they found out that their team made it to the finals, and they'll be competing against 8 other teams across the nation. And our Wayne State team, I think everyone or most of them are here. Our AMC president, Fadi Manuel, our immediate past president, Shivan Patel, our treasurer, Rachel Christensen, she's here, and Hussein Safawi, that's the team. And we'd like to also thank the advisors that were part of this, Dr. Stacy Rapotsky, Dr. Victor Nguyen, and of course our presenter today and founding member of Wayne State AMCP, Dr. Zach Mueller. We have a question here. Dr. Mueller, how do they come up with the benchmarks that you gave out in the examples?
So Medicare has they can keep track of how much money they have. They're the payer. So they keep track on their end of how much money that they have spent for services, for similar services across the healthcare continuum. I think Medicare, really big. It's the federal government, everyone over 65. And so they can see how much they normally spend on a diagnosis for a certain patient in a certain area. And then they can look at all the hospitals that they pay, and they average it out, and they say, okay, it normally costs us $200 million in Michigan for stroke patients a year. And then they can go ahead and tier that down and see, okay, well, let's set it there. Let's see if you can spend less than that this year. And so the health systems are tasked with providing that same care or preventing strokes altogether. And then Medicare doesn't have to spend the money on that. So they look at the past years and how much money that they paid out, and that's where they set their benchmark. And so, it could be an interesting thing of, do they we will have to see.
Thank you very much.
Did you get the answer? It says my internet's being goofy. So
I think we got the most part. If anyone else has other questions, you can send me a direct message or put them into the group chat, or just unmute yourself and ask Dr. Mueller.
Yeah, I had a question. How often do they calculate those benchmarks? And
well,
sorry.
No, go ahead. Finish the question. Sorry.
It's like, how often do they calculate those benchmarks? And then can health systems kind of argue against those and say we need more money, or?
Well, so the contracts are signed every 5 years with Medicare. And so the payer can set the benchmark wherever they sort of want, but then you could pull out of the contract. You can say that's unreasonable, that doesn't make financial sense for my organization, and you could pull out of the contract. So that's where the check and balance would be, is that the payers can set those metrics, but the health system doesn't necessarily have to sign into that contract. So that happens in boardrooms that that I haven't been in yet. So we will. I'll let you know when I get to negotiate my own accountable care organization contract.
Any other questions? I think that's all that we have so far.
All right. Well, thank you all for coming and spending some of your virtual time learning about this, and good luck. I think, well, you only got a few months left in the semester, so good luck to y'all, and hopefully I will see you around, and hopefully you're SMPA members.
A lot of us here are, but we'll recruit as well. And for those of you that are in the meeting right now and are not AMCP members, it is getting close to the end of the year, and we will be having our elections for our new leadership team Fadi, could you give any information about how people can join the org if they're interested?
Yeah, I can send out the link in a follow-up email on how to like get a membership. It's $45 for the national membership and $5 for the local fee. It is required if you want to run for a leadership position at our org, but we'll send out more details. One other thing is our last meeting or our last seminar, which will be held on Tuesday, March 23rd at 6 p.m. We will be giving away a free AMCP membership. So if you attend the meeting, we will be doing a drawing, and then the winner will receive a free AMCP membership for a year. So basically saving you $45. So make sure to attend that, because it will get you into the organization without having to pay anything. So, but I'll send out more details about, the Venmo for our local fee, and then the website and the link to sign up if you are interested in a national membership.
Okay.
Go ahead.
I think that's it. I was going to close it, Fadi, but if you'd like to close it, I think our seminar is pretty much done.
You're dressed nicer, so I'll let you close it. I'll look more professional.
Okay, so we just, on behalf of Wayne State's chapter of AMCP, we'd like to say thank you to everyone for attending, especially to Dr. Mueller for taking the time today to educate us about managed care pharmacy and this aspect of managed care pharmacy. We'll see you again in a few weeks for our next, our third part of our third and final part of our three-part seminar series. We have Dr. Tom Grigowski. He'll be our speaker. And keep a lookout as well, because Fadi here has set up a collaboration with the U of M AMCP chapter. So we have a lot of great things planned still for the rest of the semester, as well as big things for the fall. So the P&T competition will be happening again, and we'll be expanding our efforts with the local competition at Wayne State first before we send the team to the national competition. So on behalf of our team here, thank you very much. Enjoy the rest of the day, and hopefully you guys get out there because the weather's beautiful. Thank you, everyone.